friends, welcome to T4 Tots to Teens Tidbits, our first T4 talk of 2024. And I am here, Dr. Alanna Bree, host of T4, and I have the great pleasure of co-hosting with my colleague and friend at Sagis. As everybody knows, he's already famous, doesn't need an introduction, but Dr. Thomas Davis. We're going to be doing CPC cases together. So I am so excited for this opportunity for us to do this collaboratively. All right. I don't know if you want to jump in here, Dr. Davis, but
Sure.
Don't forget to register.
Yes, exactly. Wanted to remind everybody to register if you haven't already for the upcoming Derm Path Core Review. We will get the slide deck and the question sheet out 7 days, 10 days before the actual discussion date. The discussion of the cases will occur on February 10th. That's a Saturday. Excuse me, between 12 and 3:30. No fear, the session will be recorded. So if you can't make the discussion, you can go back, or if you get brain overload during the discussion, you can go back and watch the discussion of the answers that will be recorded. So make sure you register and pass the info along to anybody who you think might be interested as well.
Yeah, highly valuable and free. Did I say
That's
free?
right. Mm-hmm.
Right? Yeah,
Nice.
so there's the link, and I know that you guys will be getting emails too, so be on the lookout if you haven't found them in your inbox. All right, so we are going to jump on with case number 1. So I'm going to just share a little bit of history on these cases first. Dr. Davis is going to jump in and share some path, and then I'll wrap us back up with just a few clinical pearls about the diagnosis. So this first case, it was a little one, about 10 months old, that came in to see me. And first, mom had noticed these little brown speckles all over that were increasing in number, were asymptomatic. And on clinical exam, those were just flat macules and a little bit darker than the skin, and there was no perceptible scale. And then the reason mom brought baby in is because baby started to develop these lesions on the scalp, which were increasing in number. And they were kind of almost waxy looking papules, and they kind of had this yellow appearance, and then had a little bit darker center in all of them, and probably had about 8 or 10 scattered on the scalp. And I will turn it over to Dr. Davis here. If we biopsy the lesion on the scalp, what would it show?
Exactly. So let me go ahead and share my screen. And can you see the screen? Okay, on mine.
Yep, I can see it.
So you can see we've got a shade biopsy, and there's a nodular infiltrate in the dermis. As if we zoom in, we can see that the overlying epidermis is thinned with effacement of the reedy ridge pattern. And even at low power, you can get the feel for the fact that the infiltrate is composed in large part of histiocytes. The cells have fairly abundant pale staining cytoplasm. If we move into higher power, we begin to see some of these histiocytic cells, and you can see that many of them are lipid laden. So we've got foam cells within the infiltrate as well. Some of the cells are multinucleated. There's a mixture of lymphocytes and a few granulocytes. But actually, what I think you're drawn to are the presence of the characteristic of Langerhans cells. These are lipid-laden histiocytes. They're multinucleated. You can see the characteristic pink center, ringed nuclei, and lipid, which has accumulated out at the periphery. And so the constellation of features in these sections is diagnostic of a juvenile xanthogranuloma.
Very good, very good. So in this setting, with multiple cafe au laits and multiple xanthogranulomas on the scalp, you do want to be thinking about NF, neurofibromatosis 1. And interestingly, when I asked mom, I was like, so is there any family history of neurofibromatosis? And she's like, oh yeah, I wasn't worried about these brown spots. We see them all the time. They run in my family. So known history of neurofibromatosis, so didn't have to share that diagnosis. And a lot of times, these JXGs are so clinically diagnostic almost, especially in the setting of a baby with diffuse cafe au lait, that I don't usually biopsy these lesions all the time, just to save the baby from having to get a biopsy. And especially on the scalp when it bleeds and they cry and then it bleeds more. But multiple lesions usually are present. About up to 30% of kids with cafe au laits less than 2 will develop a juvenile xanthogranuloma. And then if they do have multiple lesions on the scalp, especially on the face or around the eyes, you do want to send them for an ophthalmology exam because they can get them in their iris and bleed and cause problems. And then the main risk is this risk of these leukemias, the juvenile myelomyositic leukemia. And there is really no standard of care as how often you should order a CBC. There have been some, recommendations out there, and it varies widely. So I usually at baseline, if I see a kiddo with multiple cafe au laits and JXGs, I will get a CBC and then just tell the parents that that's something that if the baby starts acting differently than normal, we might want to repeat the screen, but I don't set a certain time limit of how often I screen. So those are the clinical pearls for that. And then we will move on to the next case. So as you can see, this was a teen that came in, very worried cosmetically about this condition, was a little bit overweight, increased BMI, but otherwise a healthy kiddo. This was a little bit itchy.
Alanna, I think you need to share your screen.
Oh, am I not sharing? Sorry. Thank you. Here we go. It is, there we go. I've not done this whole screen sharing thing.
Exactly. It's a little wonky.
It's a little wonky, but we can make it work. Okay. Let me put that down. Where's my Zoom? There's my Zoom. Well, I'll be better prepared for next time, but let me get back to screen sharing. Oh, there we go. All right, here we go. Sharing again. Thank you.
Mm-hmm.
All right, so from the current screen here. So basically, again, a kind of teen, worried about this, a little bit itchy. And as you can see, there's these papules that are coalescent into plaques, a little bit hyperpigmented. And this is also can be a clinical diagnosis. You do want to definitely do a KOH, but you may want to do a biopsy if you're questioning the diagnosis. And we'll let Dr. Davis share that.
Yes, let me go ahead and bring up the case. There we go. And we'll move on to case number 2. And in this bisected punch biopsy here from the trunk, as we zoom into high power, despite the clinical appearance here, the epidermis really is not that acanthotic. Clinically, you would kind of expect that, nor is it hyperpigmented, which is a little perplexing. But what we do see is really pronounced papillomatosis. So you can see the epidermis is thrown into folds. There's really not any significant inflammatory infiltrate within the dermis, but there wasn't much clinical erythema with the lesions. And you can see that the cornified layer is actually thickened by basket weave hyperkeratosis. There's no compact hyperkeratosis or parakeratosis, but we do have basket weave hyperkeratosis, papillomatosis, and notice really no increase in the amount of melanin pigment within the stratum corneum. In light of the clinical findings, of course, these changes would be most suggestive of CARP, confluent reticulated papillomatosis of Gougeron-Carteau. I will add parenthetically, however, that histologically, one cannot distinguish CARP from acanthosis nigricans, and so that really requires clinical pathologic correlation.
Perfect. Perfect. Okay. So going back to my screen share here. So, yep, that is the diagnosis. The KOH was, of course, negative. And this is considered to be a disordered keratinization disorder, and there can be increased expression of keratin 16. And then, questionable, this has been related to malassezia furfur in the past. And now they think that it might be due to this gram-positive aerobic actinomyces called, and I'm going to maybe butcher this, Dr. Davis may be able to say it better, Dietzia papillomatosis.
Yeah. I think-
Yeah. And this kid was very bothered by it. And so the first line treatment is oral minocycline. And luckily he was not allergic to that medicine, so we could prescribe it. But if he were, the second line would be azithromycin. All right. Moving on to the next case here. All right. So this was it was a tween, probably about 10 or 11. The family had gone to Central America for vacation and been on the beach a lot. And basically these spots started developing when they got home, got really itchy, seemed to be expanding. And the family was very worried. And the child just said it was itchy, and they came to me. Again, usually a clinical diagnosis, but if you were to do the path and send it to Sagis Diagnostics and Dr. Davis read it, this is what he would find.
Exactly. And I'm sure, too, I will add, just before we discuss the slides, I'm sure one of the first things you do be to do a KOH on this, wouldn't you? I mean,
absolutely. Yep. With that scale and on the foot and kind of in between the toes, for sure. Yep. Good point.
So let's go ahead and move on to the next case. And let me bring it up. In this case, we do have a shape biopsy. It's been trisected. I think even at this low power, you can see there's quite a bit of papillary dermal edema. We'll focus in on this middle piece because that's where we have the densest infiltrate and the most edema. As we zoom in, you can see that there is parakeratosis and neutrophils, a little purulent scale crust within the stratum corneum, which reflects what we were seeing clinically. The papillary dermis is quite edematous, and within the underlying dermis, there's a superficial perivascular and interstitial infiltrate that contains lymphocytes, but if you zoom into higher power, and I'm going to get my pencil here, you can see that there are scattered eosinophils within the infiltrate as well. And in and of itself, without benefit of history, this is consistent with a response to an arthropod assault. My experience has been, obviously, given the clinical here, you would be thinking about cutaneous larva migrans. I've seen myriads of biopsies over the years. Only one time have I ever seen the organism in the stratum corneum, and that's because it migrates, and so it's like finding the needle in the haystack. I no longer have the slide. I had a slide. The organism was present in one section on one piece of the slide. I tried to get some steps for studying it. It was way before we scanned slides, but if you are lucky enough to see the organism, it will be fairly small, and it's usually in spongiotic foci within the lower spinous layer.
So fun. I love it. Okay, let's go back to sharing my screen here. All right. My little drop down is just not behaving. I think there we go. Perfect. It should be coming up now for our next case. There we go. Perfect. Yeah, so cutaneous larva migrans certainly, as you guys know, again, does give you this clinical serpiginous kind of looking eruption caused by hookworms. And it will typically die within the host, a human host. Again, most people don't want to wait, and this person did not want to wait either for treatment, but it will die in the host in 5 to 6 weeks. Then it can get a little bit more inflammatory as the body does kind of clean that up, kind of like scabies. But you can do anti-helminthic therapy. So you can certainly do like thibendazole, albendazole. Ivermectin is an off-label indication, and that's what we ended up giving this child, was a course of ivermectin. Which is overall very safe, and you can give to very, very young children. So that's what we ended up treating with. All right.
Are there any topical formulations you can use, Alanna? I was just curious.
Not that I know of. I think it's oral. I mean, you can use topical, but I've heard that they're not very effective.
Yeah,
Now, I mean, I know you can get them compounded, and I do think they're available, but when I read over it, it wasn't very effective. So we ended up doing oral, oral ivermectin.
You know, and I've seen a couple of cases that get pretty impetiginized too. You know, they can.
Yes, yeah, for sure, because they're scratching at it because it is itchy. Yep, for sure. Yeah, and when you tell a tween that they got a worm in them, they're just not really ready to just say it's okay, it'll go away, and the parents aren't either.
Yeah.
We practice in the real world.
Exactly.
All right, so this next case. Sweet little girl, who, felt so bad for her. She had kept this quiet. She was about 8 or 9, I think, kept this quiet from her parents and was doing self-care by this age as appropriate. And finally told her mom, who of course was mortified when she took a look, that this had been going on. And then they were trying to put some topical medicines on it. I think they tried antifungals, they tried topical antibiotics with the pediatrician, and it kept progressing and started to get really painful. Saw this little girl in clinic. And the first time it was really even more inflamed than this, like I could hardly examine her. This was after doing treatment with topical steroids, a class 1 topical steroid for a week just to get it calmed down. And then she came in, it was a little bit easier to get her an exam. And again, it's really important in kids to go over that you're going to be touching them. It's very traumatizing if you do it the wrong way. So again, being very slow, very gentle. This is a time to just kind of take a deep breath and not try to rush to the next patient, even if you're behind. It's best just to have them, have mom and dad take off, explain what you're going to be doing, take off the underwear as well as the pants, and just kind of then, have the sheet over them, have mom do that while you're outside of the room, and then come back in, explain what you're going to do. And then again, put them in their little kind of, frog leg position, and tell them that you're just going to gently have them put their legs down, and again, let them go real slowly, and then kind of say, okay, now you're going to feel my hand with a glove, and you're going to first feel it on your leg, and then kind of go inward and tell them, this is a sensitive area. It's only okay if mom and dad are here, and you're at the doctor. And I just always say that when I'm examining children in this area, and letting them know that we're going to go slow, but it's important for me to take a look. So when I was able to actually take a look, you can see this kind of thick scale. You can kind of see almost this hypergranulation tissue in the genital area, a lot of erythema. And then she was laying on her belly for this other picture here. I don't know if you can see my cursor, but that's actually kind of the perianal area that was eroded and just really so painful. I asked about GI symptoms, of course. And mom said, yeah, she'd always been constipated for a really long time, had some occasional diarrhea that, they were treating through the pediatrician. And so, of course, you can get a biopsy of this area because it was so tender. I actually didn't. And again, in kids, a lot of times we do other things besides biopsy. In adults, it's really smart to just, biopsy as often as you can. But in kids, you really try everything else before you kind of get to that point. And I really thought with her GI symptoms and this, it was important to refer her on. But if you were to biopsy this,
exactly. And I actually have the biopsy that I'm going to be showing you was actually from a male who was about 4 years old, almost the exact same history, and presented with a massively swollen scrotum. And,
Mhm.
and I'm sure you've seen that as well too.
Oh, yeah. Yep.
And he did report a history of some abdominal pain and diarrhea, and was in the process of being referred to a pediatric gastroenterologist. So let me go ahead and share, and we'll move on to the next slide. I had the benefit of seeing 2 biopsies from this patient, and you can see we've got a bisected punch biopsy. And we'll just focus in on this middle piece. Both halves show similar changes. As we move into higher power, you can see that there are nodular accumulations of inflammatory cells around vessels of the superficial and deep plexus. There's a little bit of epidermal hyperplasia and spongiosis. And if we zoom in, we can see that we've got collections of epithelioid histiocytes, some multinucleated, surrounded by a cuff of lymphocytes or mononuclear cells. So we've got tuberculoid granulomas here. Certainly in a case like this, we're obligated to do bug stains. So we did PAS, tissuegram, and GMS and AFB stains, which were stone cold negative. And certainly in light of the clinical presentation of our patient and this patient, we felt that this was almost certainly cutaneous Crohn's disease, actually metastatic Crohn's disease. And this patient on biopsy, GI biopsy, did have confirmed Crohn's disease. So.
Yep. Yep. And you can just see how intensely inflamed that is, both on the skin and under the microscope, right? Like you can kind of appreciate that so much. Yeah. So
let me just launch mine again, and then I'll stop share. Okay.
All right. Perfect. And here comes my screen share.
Did she end up, I'm sure she ended up having Crohn's, didn't she?
She did. She did. Yep. Yep. Exactly. And yeah, it's one of those times where, a lot of times this will happen after the diagnosis, but this was, I think really, no, I guess I did have a kiddo, a little boy that had more testicular inflammation that we were the first ones to make the diagnosis. And again, I usually don't share. I'm just like, there could be something going on. And because again, I try to limit what I tell the family if we don't know, just because they're going to go on the internet and look stuff up. So I was just like, there can be inflammation on the inside, and it's important to go to a GI doctor. And again, of course, it confirmed it. And with her treatment for Crohn's, the skin did get a lot better. And just for, we went down to a lower potency topical steroid just for the local, kind of inflammation and pain control. So anyway, yeah. And about 33% of patients, they say, with Crohn's will have cutaneous, I'm sorry, that if you have so if you have Crohn's perianal fissuring, that 33% are going to, have that. And it is indicative of colonic involvement. And the skin can get better with the oral treatment, mesalamine, or other treatments that are now out there. But yeah, this family was so thankful that we identified that for sure.
Yeah.
All right. So next case here. All right, so this was a sweet, sweet girl that came in. She was about, I think, 8 or 9 no, maybe she was probably about 10 at the diagnosis, or at the time of diagnosis. And she had gone to multiple people, had been getting lots of different treatments for eczema, for rosacea, on her face. That's where she first had the skin lesions. And then she really started developing lesions over her elbows, and her knees looked very similar. On history, she was an otherwise healthy kiddo. I asked if she had any other real symptoms. Mom said no, she's been growing and developing well. And so there's some more questions that you can kind of ask in this setting if you're worried about it. Certainly, does she get tired a little bit more lately? And when they started thinking about that, the answer was yes. And then I said, you know, as far as PE, how are you doing in PE? Is that kind of, she said she really liked PE, but she did say, well, maybe when I'm running, I get a little bit more tired than I used to. And so that was kind of the clues in history that helped us. And the rash was a little bit itchy. They didn't realize that it was kind of sun-induced, but she did, after questioning, say, oh yeah, maybe after we go outside, it does get a little bit worse. And so if you were to biopsy one of these papules on the elbow, again, if you have a choice of places to biopsy someplace that the scar is not going to be seen. So the elbows and knees, don't go biopsy right on her cheek, where that's going to be visible for the rest of her life.
Yeah, I'll go ahead and move on to the biopsy. Okay, and we, in this instance, have a bisected punch biopsy. And at first blush, you know, there doesn't seem to be much in the way of an inflammatory infiltrate here. The epidermis, there may be a little effacement of the reedy ridge pattern. You can see that the dermis here looks a little blue. And if we zoom into higher power, the dermal epidermal junction here is actually quite smudgy, just not real crisp. And you can see that there's quite a bit of pigmentary incontinence. We've got melanophages present in the dermis, a little vacuolar change, and actually you can appreciate some thickening of the basement membrane zone here. There are dilated vessels, and there are copious amounts of mucin present within the dermis here, all in concert with just a fairly sparse perivascular infiltrate of lymphocytes. Now, when we see these biopsies histologically, all we can do is sign this out as consistent with connective tissue disease, because I'm sure, as many of you know, there have been a lot of very good studies that have pointed out the fact that you really cannot distinguish SCLA from dermatomyositis on histologic grounds. So you really need clinical pathologic correlation. That being said, when I see this sparse of an infiltrate and this much mucin, I'm really kind of thinking more strongly about dermatomyositis.
Perfect. This is so fun, by the way. I am having so much fun. Basket weave hyperkeratosis Langerhans cells. I'm like,
Exactly.
Anyway.
Good
All right. So going back to screen sharing with mine here. So this sweet little girl, I did examine her. And a test that you can do is the head lag test, right? So little kids, you tell them to lay their head on the pillow and then you kind of pull them up. And if their head lags back, that does mean that they have proximal muscle weakness. And it usually means it's pretty extensive, you know, that the disease is probably pretty progressed at the time. There have been some infections that have been implicated, with causing this, parvo B19, Coxsackie, enterovirus, strep, as well, has been thought, because there seems to be in the juvenile cases a clustering that seems to be seasonal. Certainly the Gauthrin's papules, she did have those. Those are kind of pathognomonic, as we know, but this heliotrope or periorbital rash, they talk about it looks like glasses around the eyes, kind of how it goes over the bridge of the nose like that. And then certainly the elbows and knees, you see that all the time in the juvenile type. And then, you know, you can check labs. A lot of times, if I know I'm going to send these kids to room anyway, I've quit checking labs because then it ends up getting them 2 blood sticks instead of 1, but you could certainly have increased CPK, increased aldolase, you could have an increased ESR. Certainly there can be, the lupus panel can be positive as well. And myositis specific antibodies. And the nice thing about children is they don't have that increased risk of malignancy, but they do get more calcinosis. And she did improve quickly with Plaquenil, and then she ended up being on more systemic treatments. Of course, got it under control with systemic steroids first. And then the Plaquenil seemed to...
Oh, I'm sorry, go ahead.
Yeah.
I'm just going to point out, you know, if you look at the elbow there, it almost looks like she may have a little calcinosis cutis.
Yep, she did. Yeah. And so yeah, I was like, we need to get you. So this was a call to get her into room quickly, just so that she could get treated. And then we had talked about the Plaquenil, but of course, Room managed all of it at that point. And she did get a lot better with treatment.
It's pretty, I mean, it's a pretty rare condition in kids, isn't it?
Yeah, it's pretty rare. I've seen a handful over the years. And yeah, it's, and then as far as like it really being amyopathic,
Yeah.
I always hope that that's what it is, but
Yes.
I'm going to tell you that's exceedingly rare. And it may be amyopathic at the beginning, but usually never ends up being that. And the gold standard for treatment, of course, is to get the imaging with a muscle biopsy.
Yeah.
So again, I just don't put these kids through labs if I'm going to send them to Room, because I know they're going to get a big deal workup and be put through a lot. So yeah. Okay. Next case here. All right, so this was a baby that we saw just right after birth, had been sent, normal spontaneous vaginal delivery, first child, and baby came out, looked a little bit red. And then as they were doing the first bath at the bedside, it seemed to be causing erosions, and then sent the baby, of course, to the NICU because they were worried about infection, and they called us. And this had the benefit of history that I'm not going to share right now. But you might do a biopsy in this baby, but we didn't need to because of the family history.
Okay, let's go ahead and take a look at what the biopsy would show. Let me get my screen brought up here. Okay. We'll go ahead.
I need to quit sharing. Okay, you got it.
And we do have a punch biopsy here. And even at scanning magnification, you can see that the compartment of the skin that's involved, the action is going on in the stratum corneum and epidermis. As we zoom in, we can see that there's marked hyperkeratosis and a little bit of papillomatosis. The cornifine layer, there's a little bit of perikeratosis, a few retained nuclei, but mainly we've got compact and basket weave hyperkeratosis. If we take a look at the epidermis, it's very clear here there's disordered maturation. And the changes primarily affect the upper spinous and granular layers, particularly the granular layer. And I'm going to draw with my pencil here. You can see the granular layer is quite thickened. The keratinocytes in this area do demonstrate, and I'm going to zoom into a little bit higher power, ballooning or intracellular edema. The cytoplasmic margins are indistinct, and it's almost like the granular layer forms a syncytium and is sharing the keratohyalin granules. And this constellation of histologic findings is pathognomonic for epidermolytic hyperkeratosis or granular degeneration. Now, you'll remember that is an epidermal reaction pattern. And so when we look at this biopsy, it doesn't mean that the patient has epidermolytic ichthyosis. Given the broad nature of this, one would expect that. But remember, we can see this finding in epidermal levi, which may be mosaic variants of epidermolytic ichthyosis. We can see it in benign keratoses, and we can also see it as an incidental finding. But in this setting, with this presentation, one would have to favor the diagnosis of epidermolytic ichthyosis.
Awesome. All right, going back to screen share here. So now I have a question for you, actually. So if you were to biopsy one of those erosions, because, epidermolytic ichthyosis, there's not much scale, and they come out kind of ooey gooey. Do the eroded or bullous lesions show that at the edge? If you catch the edge?
Typically, sometimes you'll get a full thickness defect, but a lot of times the split will occur in the granular layer because it's all, or just below it because there is loss of attachment there.
Okay. So the edge of the bullous lesion, if you're wanting to confirm would be.
Right, because it's going to
place.
show that an intact epi.
Yep. Okay. That's what I kind of thought. All right. So yeah, we didn't have to biopsy this baby because mama had epidermolytic ichthyosis, which is the majority, huge majority is autosomal dominant mutations or changes, point or missense mutations in K1 and K10, used to go by bullous ichthyosiform erythroderma when I was a resident, and EHK, epidermolytic hyperkeratosis. But we know now that it is, within that ichthyosis family. And so this baby ended up doing fine. Mom wasn't too troubled by it. Again, less is more. As far as treatment, just, they're in this bullous phase initially, and then it progresses, but really just kind of minimal wound care is what you recommend for that. So anyway.
I'm sure there are probably variable expressions of the disease as well.
Oh, yeah.
So.
Yep, for sure. And, a lot of times these kiddos get a big, huge workup. So just because of risk of infection, right? And other kind of rare disorders. So they always kind of freak out when they see this. And I was like, no, this is really it. They wanted to make sure that it fit because, they looked at the mom and the mom looks very different than the baby. Sure. And they're like, is this really how it manifests? I was like, yes, this is really how it manifests. Yeah. So, okay. Next case here. All right. So this was a young one who came in, again, this teeny tweeny age, had come in and had these diffuse lesions. Some were very annular, no perceivable scale, scattered kind of on the arms and legs. And then you had these more nodular lesions. There was one on the foot, and there was actually one up on the forehead of the more nodular lesions. So very worried because they were increasing, they were asymptomatic, but the child didn't like them just because they were obvious, but otherwise totally asymptomatic, healthy kiddo. And if you were to grab a biopsy of one of these lesions, and if I remember right, since I've been retired from clinical care, you biopsy at the edge of one of these lesions. Is that correct, Dr. Davis?
Yeah, that's where you're going to get your highest yield. And we'll take a look here. Okay, move on to our next case. Here we've got a punch biopsy, likely from the edge, bisected punch. I think we will. Let me tilt the slide a little, and we'll focus on the bottom piece here. And no surprise, the epidermis is totally uninvolved, correlates with what we're seeing clinically. There is an infiltrate of lymphocytes present around vessels of the superficial plexus, but you begin to see that there are nodular accumulations of cells in the dermis here. And as we zoom to higher power, we can see that these are histiocytes. They definitely have larger nuclei than the lymphocytes. They have abundant pink staining cytoplasm. There's some multinucleated cells. And if you notice, these cells are arranged in a vague palisade around collagen bundles, which are separated from one another by an increased amount of dermal mucin. And if you note, the collagen bundles are normal in appearance. They're just getting pushed out of the way. This is in the distinct difference than what you see in NLD, a distinct contrast, because in NLD, you actually get degeneration of the collagen. Here, the collagen bundles are left intact, which is why when GA resolves, it doesn't heal with scarring. There's no destruction of dermal collagen. You can get some post-inflammatory hyperpigmentation, but usually there's no alteration in the collagen. I suspect in this patient too, Alanna, that biopsy of the deeper nodules would show subcutaneous GA, deep involvement. So,
yep, exactly. So very good. Palisading granulomas. Again, all these words I haven't heard in so long. So exciting. All right, so going back to my screen share. All right, so yeah, this kiddo, Of course, the things that can be associated with it more so in adults and in children: diabetes, autoimmune thyroiditis, malignancy is rarely associated with it, HIV, lymphomas. But really, they wanted a treatment. So we tried topical steroids, didn't do anything. I did like it under occlusion, topical steroids under occlusion, did tacrolimus. That's when, this was an older case, that's when tacrolimus topically had just come out. So gave that a whirl. Not great results. So we ended up, just because the child was so bothered, I'm like, these are going to go away. We don't have to treat them. They're not bad for your health, but really wanted treatment. So we did oral Plaquenil, and it did seem to work. Of course, that's off label, but so much of what we do in Pedi Derm, and would it have gotten better without it? Maybe, probably. But if it was a placebo effect, they were happy with the effect. And overall, Plaquenil is pretty benign in children, and they tolerate it well. All right, so next case. So this is a kiddo that came in and did not have this lesion at birth. They thought maybe they had seen a blue discoloration several months before when they went back and looked at photos. But then it really started to enlarge, and you can see here had loss of hair over it a bit. And so we ended up, because the child wanted it gone because it was painful. And because of that, I knew we were going to excise it. So we did not. That's a big thing for me. If I know I'm going to do an excision anyway, I don't put the kid through a biopsy in clinic, especially if we're doing the eye. I know we're going to be doing it under general. So again, we ended up putting this kid under general, and the pathology confirmed what we thought clinically. And so this is what it would show.
Good. Let's move on here. And in this excisional biopsy specimen, no big surprise, we've got a vascular tumor given the clinical appearance. It's extremely sharply circumscribed, extending from the deep dermis into the subcutaneous tissue. And you can see we've got a lot of dilated vascular channels here, many containing RBCs. If we take a look at the lining, let this settle down a little bit. So pixelating a little, but should come into focus momentarily. We do see that many of the vessels, look up here, most of them are lined by flattened endothelial cells. But at the periphery, we've got an accumulation of very monotonous appearing cuboidal cells with round nuclei and a moderate amount of pink staining cytoplasm. And some of these form a string of pearls around the dilated vascular channels. And this combination with the dilated vessels lined by endothelial cells and these uniform cells is compatible with the diagnosis of a glomus tumor. I will add that sometimes when the vascular component isn't so pronounced, when you've got these modified smooth muscle cells or glomus cells compressing the vascular channels, these tumors can really mimic a poroid tumor. And sometimes your adnexal tumors can be painful as well. So occasionally we're relegated to doing immunohistochemical staining for smooth muscle actin for a glomus tumor versus a cytokeratin stain for one of the poroid tumors, which these can mimic. So probably more than you wanted to know, but.
No, I think that's great information. And yeah, it shelled out kind of real easily like that. Like it was actually a fun little surgery to do, just because it.
Tough location though.
Yeah. Oh, it was a tough location. And we did a pretty good little Z plasty kind of thing to bring the eyebrow together, and it healed really pretty well. And he was just happy because it was so painful for him. So yeah, so this condition, what's the other, glomovenous? I think it goes by another name.
Yes, malformation.
Yeah, malformation. And so these can be familial in about they say about 40 to 70% of cases, no treatment is needed, but if it is painful, the treatment of choice is just excision with rare rate of recurrence. So yeah, they were very happy. And I usually try to talk people out of it, but it was symptomatic. So I'm like, let's just get rid of this guy. All right. So this case, this was a, gosh, I want to say she was about 11. So a little bit old for this diagnosis. But she came in and she had developed kind of some abdominal pain first, and then they started noticing some lesions on her lower legs, and over a few days they really kind of progressed. When you saw this kiddo, if you look up close, she definitely had these purpuric macules that were somewhat hyperpigmented, and she also said that her joints were really uncomfortable. And so this is a pretty classic clinical diagnosis, but sometimes you want to get pathology just to confirm that diagnosis.
Yeah.
And Dr. Davis will share what that is.
Well, and we're increasingly, I will add, seeing in this setting, biopsies for H&E and IF coming in at the same time. People for IF just to kind of confirm the diagnosis. So we'll go ahead and pretend we're looking at a microscope. I'm not going to tilt the slide this time. We do have a punch biopsy. You can see that the epidermis is remarkable. This punch biopsy is from the lower extremity, relatively thin dermis, and you can see some fat down here. We've got a perivascular and interstitial infiltrate within the dermis, and so it's likely to be mixed. And as we move to higher power, we can see that surrounding these vessels, there's an infiltrate of lymphocytes, but there are also a lot of neutrophils, neutrophilic nuclear dust, and we can see fibrin rimming these vessels. Fibrin is present not only in the vessel walls, but a little present in the vessel lumina. And I usually like to point out to the residents that, if you see this strawberry donut type pattern, because the fibrin looks like surrounding the vessels, they look like strawberry donuts with blueberry sprinkles on them. And that can be one of your clues to the diagnosis of leukocytoclastic vasculitis. And I'm sure in this case too, there was IgA deposition around the vessels as well. So
that made me hungry. I just started a keto diet 2 weeks ago, and strawberry donut with blueberries really.
You're like, yeah.
Gotta wipe my mouth.
Exactly.
Yeah. So, yep. So you'll have your palpable purpura, and just like Dr. Davis said, if I am going to do a biopsy, I like to move it, on her thighs, not her lower legs. It's going to heal better. Number one, and number two, you want to get a fresh lesion, but not too fresh, right? So how old of a lesion would you say?
Well, you want, for H&E to confirm the diagnosis of vasculitis, it's good to get a late lesion. You don't want one with extensive epidermal necrosis, because you can get a secondary vasculitis if you get an erosion or ulceration. So you want a well-developed lesion. However, for the purposes of IF, you want perilesional scan or a very new lesion, because as the vasculitis progresses, the inflammatory cells will destroy, and the enzymes will destroy the antibodies. So,
Okay,
yeah.
Very good. So yeah, IgA, certainly positive. You can bisect a biopsy and just do one lesion in a kiddo, which is what I like to do. Just do kind of a 1 millimeter bigger punch and then bisect it. And then of course, if you are going to be staining, doing the IgA, you have to put it in different media. So don't have your staff throw it in the same bottle, different bottles, but formalin, right?
Yeah, you want Michelle's media. It's a transport media.
Yep.
Or you can, if you're very close to the lab, you can put it in normal saline.
Yep. And that's what I used to like to do, just on gauze, and yes, the normal saline, especially if I was doing it in the children's hospital where they had to go, before I could use the wonderful dermatopathologist at Sagis when I went into my own practice. But yeah, so HSP, it can be recurrent. It's important to tell them that. You do want to check a blood pressure. Those can be elevated. Hers was normal. And then you definitely want to check a UA and let them know if they start seeing blood in their urine or their stool. It's something to definitely alert a physician about. And I ended up doing oral steroids on this girl because her joints and her GI symptoms were bad enough. Her UA did come back negative. And I just called the pediatrician and got follow-up scheduled with them, and she ended up resolving. She did have one recurrence, but other than that, it was just a little burst through, I think, after the lesions had resolved. And it might have been that she was up on her feet because she was feeling better. So it seemed to, go gravitate down. All right. So this was a teen that came into clinic. She was developing these lesions that got very extensive. They had mild scale on them, but I wouldn't say excessive scale. She had been seen by another dermatologist and diagnosed with tinea versicolor and given oral, because of the extensive nature, she had been given an oral antifungal, didn't help, and ended up coming and seeing us. We did a skin biopsy on her.
Were they asymptomatic, or was she?
Asymptomatic. They were really pretty overall asymptomatic.
Good. And it's going to be, a tough diagnosis to make. It can be, the findings can be very, very subtle. I'm going to flip the slide here, so you won't have to stand on your head. And you can see that we've got a bisected punch biopsy from the trunk, very, very thick dermis. And, even on scan, you can see the epidermis is somewhat hyperplastic, and there's an infiltrate, which is confined to the papillary dermis. As we move into higher power, it's kind of band-like. And so we have this psoriasiform ligoid infiltrate. As we zoom into higher power, clearly here, you can see that the epidermis here is infiltrated by these cells, which on higher power can be seen to be very large lymphocytes. These are hyperchromatic. They have very irregular nuclear contours. There's also a patchy infiltrate of lymphocytes with a thickened papillary dermis. And when you're looking for lymphocytes and assessing nuclear atypia, keep in mind that lymphocytes normally have a diameter of about 5 millimeters. So they should be about the same size as an RBC. And sometimes you can find a normal appearing lymphocyte here. I'm going to go ahead and get my pencil here. This is a normal appearing lymphocyte, okay? It's got nice round nucleus and it's relatively small. We'll compare that to these monsters up in the epidermis. And so these cells tend to swell with pride when they get into the epidermis, and they're forming actually small collections here as well. So we've got way too many lymphocytes here in the epidermis for the degree of spongiosis, which is what defines epidermotropism. We have a few early protease collections, and generally what's unique about most cases of hypopigmented MF is that the neoplastic cells are predominantly CD3 positive, CD8 positive lymphocytes, whereas in conventional or the common, most commonly seen variants of mycosis fungoides, we have a predominance of CD4 positive cells. So you definitely want to do extensive immunophenotyping and at times molecular diagnostic testing to confirm the diagnosis.
And those tests can be run, if I remember right, on formalin fixed tissue, correct?
Formalin fixed paraffin embedded tissue. Generally, I will add, and I think it's good to take the time to do this. In academic institutions, a lot of times what you find is someone will see a case like this, or even more subtle cases, and they order immunophenotyping and gene rearrangement studies right up front. Well, already you're dealing with a close to $2,000 bill, and patients, don't take too kindly if you say $2,000. This is just a rash, and right. So generally you want to order your test in a stepwise fashion. So I'll start with immunophenotyping, but if the immunophenotyping does not support the diagnosis of MF, and especially if the clinical's kind of iffy, I'm not moving on to gene rearrangement studies because they're not, no test is absolute. And certainly people have pointed out and written about the fact that you can get clonality, a clonal T cell population in reactive conditions, PLEVA, PLC. I've even seen them in BLKs. And so, you have to be cognizant of the test you're ordering. And I think that's something we don't always tell residents about, wouldn't you say, Lana? So.
Yeah, that's a good point, because when you're in your own clinic and they get that bill,
Oh,
they're
yeah.
going to be, calling you and yelling at you, right? So I do think having a good relationship with your dermatopathologist and knowing that they're going to do that in a stepwise fashion and let you know if that's what they're going to do, so you can communicate with the patient too, right? So that's, critical, I think, to have that good relationship. So so this ended up being hypopigmented MF. And so we did refer her to, hemonc kind of, we luckily have that here in Houston, somebody that is an expert in that, but, the increased risk of it in skin of color, the increased risk in females, and then of course, the most common type of mycosis fungoides is going to be the hypopigmented in the pediatric population. So fit clinically. And I never saw her back, to be honest, once we made the diagnosis. So.
Yeah, it's interesting. I appreciate you commenting on this. Most of the cases of hypopigmented MF that I've seen over the years, especially when they're kids, very few of them progress on. And I've seen some of them they just resolve, they outgrow it. Has that been?
Yeah, absolutely. And that's what I told them I figured, but I said, let's just, get our ducks in a row and have you just touch base just in case you need it, about that building relationships kind of thing too.
Yeah.
Then they already have an in. If she started getting, and we kind of said, if your lymph nodes get swollen, you start feeling bad, blah, blah, blah. And the thing is, you don't even really, treatment doesn't prevent the progression is what they've shown, and she had used topical steroids because somebody thought maybe it was nummular eczema too before she got to us. And that didn't seem to help. So, she was dry. She was maybe a little itchy, but I was like, I think you really just have dry skin overall, and just recommended some moisturizer and kind of sent her on. And like I said, was lost to follow up to derm. All right. So this is a sweet, sweet baby that I had the pleasure of seeing with a very nervous first-time mama. And you can appreciate here in this baby first.
You need to share.
Oh, am I not sharing?
Yeah.
Oh, yeah. Thank you. Let me go back to screen share. Technical difficulties. Oh my gosh, and we're running behind too because I'm having so much fun. All right, so these were pictures that were taken before I saw the baby by the residents in the hospital. They were called in, and then this is when I saw the kiddo in clinic. And you can see here you have these linear, somewhat Blaschko linear, you might say, kind of hyperpigmented, even almost verrucous, some erosions here with some surrounding inflammation. And then a few weeks later, this is what we saw in the clinic, again, hyperpigmented in a Blaschko linear on the arm and the leg. Not much to speak of on the trunk per se. Baby was otherwise healthy. And again, a lot of times you can make this as a clinical diagnosis, but if you want some additional help confirming that diagnosis, you can do a skin biopsy, which would show.
Exactly. And the biopsy we have here is a small shape biopsy. And as we zoom in on higher power, we can see that we've got some epidermal hyperplasia. We've got an infiltrate that's kind of obscuring the dermal epidermal junction. And as we move to higher power, you begin to see that there is quite a bit of spongiosis involving the epidermis. There's extension of the eosinophils into wide intercellular spaces. So we've got spongiosis with the eosinophils. And when we see this change in concert with these dyskeratotic or apoptotic cells present at all levels of the epidermis were almost certainly dealing with incontinentia pigmenti. So it's the combination of the two that kind of leads you to the diagnosis. Early on, when we see the vesicular lesions, we tend to see a lot of spongiosis. Over time, the lesions become progressively psoriasiform, less spongiosis, more dyskeratotic cells, and quite frequently, it's very interesting, these dyskeratotic cells in the epidermis can calcify. So if you biopsy one of the verrucous lesions, you can actually see calcified dyskeratotic cells within the epidermis.
Interesting. I didn't even realize that. Okay, going back to screen share here. So yeah, so this baby, of course, had incontinentia pigmenti. It is an X-linked dominant, sweet little girl. Mom was very worried, of course, got out on the internet. The four, types: vesicular, verrucous, hyperpigmented, then hypopigmented. And the big thing is, a lot of these kiddos, they say that up to 30% will have some eye lesions, and they do tend to develop early. So I usually recommend that they establish with a pediatric ophthalmologist early on, just so they have that connection. Because if they do have any eye involvement, it's with the vessels, and I know that it causes scarring and potential blindness. So that's really the biggest issue to me when I see them at this stage. And it is, again, X-linked dominant. It's on XQ28, and it used to be called the Nemo gene, but now it's called IKBKG. And again, it is pretty uncommon, but again, when you see it, you'll never forget it because it's so clinically classic.
Mhm.
All right. So next case, this was a kiddo that had long-standing eczema and then started to develop these lesions that were a little bit different than is typical. And he did have more of a, I would say, papular eczema. Again, kiddos with skin of color, that is a subtype of eczema that you can see a lot more. But as you can see here, he was starting to get some Kebnerized lesions. They were very worried about the lesions on the face. And when I examined his trunk, this was what you found. So if you did a biopsy,
Which, a lot of times we don't, the diagnosis is made clinically, I guess, unless it's, uber extensive. And it's skin of color, you always have to worry about sarcoid,
yeah, that's true.
But here you can see that we've got a bread-loved shade biopsy. And this biopsy was taken near acral skin. You can see a very thick stratum corneum. And we're going to focus on the top piece because that's where we have the diagnostic changes. And this is one of those, you learn about very early in residency, and you hope you get on a core exam because it's so characteristic. We got the classic ball and claw here with a very widened dermal papillae and incurvated rete. And then you can see in the papillary dermis a collection of lymphocytes and histiocytes. And of course, this is pathognomonic for lichen nitidus.
Perfect. Yeah, that's a good one. That one I think I could even still get on an exam, but I don't know. All right. So they were very worried. They were reassured that that's all it was. It does tend to improve with age. There's really no great treatment aside from treating. You can treat it like eczema, but just reassurance that it wasn't anything bad and they weren't doing anything wrong. All right. So next case. This is a kiddo, otherwise healthy, came in, first developed the lesion kind of down here is what they noticed. And then you see that it seemed to be almost in a linear pattern, which has been described. Really overall asymptomatic, but then as the lesions, they thought these two first were bug bites, and then this one got a little bigger and looked a little bit different to mom and dad. So they brought the kiddo in, otherwise healthy little girl.
Okay, and we'll go ahead and take a look at the biopsy here. And you can see in this bisected punch biopsy, flip it again, the action is kind of centered. Not wanting to blip. In the papillary dermis, again, the epidermis is unremarkable, as you noted clinically. And right away, you can see a perivascular and interstitial infiltrate. I think even a low power, you can appreciate the fact that we've got some extravasated erythrocytes there, which would correlate with what we're seeing clinically. And we've got extravasated red blood cells. We've got a predominance of lymphocytes here. So unlike the vasculitis that we saw, where we saw neutrophils, neutrophilic nuclear dust, and fibrin, here, none of that. We have lymphocytes, extravasated red blood cells, and in a few areas, I don't know whether it'll project real well, there were a few siderophages in the infiltrate as well. So really, to make this diagnosis, this is consistent with one of the persistent pigmented pupillary dermatitis, of which lichen aureus is one. You have to see either extravasated red blood cells or siderophages. So.
Perfect. Yeah, this is fun. All right, back to screen sharing. All right, so yeah, this kiddo, again, otherwise healthy, was asymptomatic. Parents decided not to do any treatment, told him it would be self-limited. And so, yeah, went away.
You know what I've noticed too, on this bottom piece, Alanna, you can see a little bit of that cayenne pepper type.
Yeah, you can right there. I don't know if you can see my cursor, but right there, those little cayenne pepper. Yeah, exactly. And those didn't really blanch out very much at all. So that capillaritis kind of appearance.
And then I've noticed, especially with the older lesions, as we get more siderophages and few extravasated red blood cells, the lesions tend to darken. You know, so sometimes clinically they can be almost blue-black, you know. And
yeah, that's true. That's very true. Yeah, this was fairly early in the course. You're right. Yep, exactly. And, you know, it got better. And
good.
Yeah, that's the good news about things in dermatology and kids. Most things get better. Now, this case was very difficult and it did not get better as much as I wanted to. It got somewhat better, but here you can see this atrophic plaque. There's these kind of plugs here. You can also see it's somewhat purpuric. And so, you know, had gone back and forth about what the diagnosis could be, because this is not the typical location, but it has very many of the typical features clinically. So,
you know,
small little.
Go ahead. I'm sorry.
Yeah. So small little biopsy was done just to confirm the diagnosis.
And you know, I would have bet dollars to donuts on DLA here. I mean, I'm sure.
Yeah, that's what it looks like, right? That's what it looks like. And that's what we kind of was our diagnosis.
Okay, and we'll see. A little bit of a shocker, but it makes sense, as you pointed out, retrospectively. This is our classic patriotic red, white, and blue dermatosis. Let's flip the slide here. And you can see that the epidermis is thin with effacement of the reedy ridge pattern, maybe a hint of follicular plugging here. We've got compact orthokeratosis. We've got vacuolar change along the DEJ. And you can see we've got a papillary dermis that's markedly expanded by sclerosis, beneath which we have a band-like infiltrate of lymphocytes. And so with our red, white, and blue, this is absolutely pathognomonic for extragenital LS.
Yep. And that's exactly, it was pathognomonic, biopsy pathognomonic. She did end up getting a little bit better with class 1. So I did clobetasol, and then we started alternating with tacrolimus. We hit it pretty hard, and it got better. Not to anything that any of us were really happy with. I find a really good response when I do that in the genital area, but did not get such a good response there.
And a solitary lesion.
It was a solitary lesion. You can kind of see here, there was kind of it never extended. I was a little bit nervous because you can kind of see it almost.
You need to share your screen.
Oh, I got to share my screen. That helps. That helps, is me pointing it out. Thanks. Yeah. So yeah, up here around her eyes, how it kind of approaches up
Yeah.
here. I was a little bit nervous it was going to go all the way up there,
Mhm.
but I don't know if we just started treating it. And this was a case in St. Louis when I was previous to getting to Texas.
Mhm.
So anyway, yeah, I did get to see her as she got older, and yeah, not the result we were all hoping for, but
No, very unfortunate.
yeah, I know. Sweet, sweet girl too. Sweet, sweet girl. All right. So this case got sent over to me. She was over in the I can't even remember what clinic at the hospital. And they noticed that she was hypertensive. And again, I can't remember what clinic sent her over, but they're like, she was a teen. And they're like, her skin just doesn't look normal for a teenager. And when she got there, I was like, yes, you're right. This is not normal for a teenager. So if you were to do a biopsy on this.
Yes, we will go on, and this is our final case. And very characteristic changes. One can see in this punch biopsy an accumulation of material or an infiltrate confined to the upper reticular dermis. And this is quite characteristic location for the abnormality to localize in this condition. As we move to higher power, we can see that actually we have very hyperplastic or thickened, gnarly elastic fibers. And these elastic fibers are encrusted with calcium. You know, when people talk about purple popcorn here, to me, I don't get popcorn here. These to me look like the streamers that you see, you know, those poppers on New Year's.
Oh, yeah.
The confetti streamers, so what you might get out of a cascarone. And these are calcite elastic fibers. And you see this change, and especially with clinical, it's pathognomonic pseudoxanthoma elasticum.
Yep. So, yeah, that's exactly what the diagnosis was. We were able to prove that genetically. And again, the biopsy will definitely be helpful if you're questioning it. Her sister actually had similar changes. So again, you know, but they didn't think any big deal because they thought that's just kind of how their family skin might be. And again, didn't really come for follow-up, but that is, gosh, what is, it's an ATP binding, I'm blanking on the name of it, but anyway, it is genetic. It's ATP binding protein, and it's ABC. Anyway, y'all are going to have to look that up because I already took my boards.
And it does require, this is the case that I think, you know, that the residents definitely can get on the applied exam, you know, because the pictures, the biopsy, and then they'll ask you about management, because obviously this requires some multidisciplinary.
Multi-system. Yeah, exactly. I think it's ABCC6. That's my guess. But again, everybody confirm that before you take your boards. And the question that they do like to ask is the eyes, the angioid streak. So that's what I do know that they have always really liked as far as on the boards is the angioid streak.
Cardiac problems too.
Yep, they can get cardiac problems. They, you know, high blood pressure. And I think maybe it was just her pediatrician that was seeing her and she had high blood pressure. And then anyway, I can't remember how she ended up with us, but I was like, oh no. And then sister was there because they had come in from out of town. And so anyway, that was definitely the diagnosis. So definitely those peds cases that need, you know, the multi-team approach. And again, you're not going to do anything for their skin. So she really never followed up with us. So I don't know what the long-term was, but very, very sweet family, and very thankful that the skin gave the clues, which is always fun when we get to do that, to be the detectives on the case. So yeah, this has been so fun. CPC detectives on the Pedi Derm cases. I've appreciated everybody's time. I know we went a little bit long, but I hope you guys got a lot of good path pearls, a lot of good clinical pearls. And certainly just want to remind you again to sign up for the Derm Path course coming up, which will be high yield and also free. So that is the sign up link, and just be on the lookout for your emails to get signed up for that if you haven't done that already. But we are going to be doing T4 talks. We're going to be doing on the 1st and 3rd of every month. So we're going to be doing it twice a month. So 1st and 3rd Thursdays at 5. We're going to have Dr. Joseph Lamb back next time. It'll be February 1st, and we're going to be going viral. So we're going to be talking about cutaneous viral lesions in children. So definitely join us for that, and join us for all those Derm Path happy hours. And certainly the core exam review is the most important. So thank you, Dr. Davis. It's been fun.
We're going to try and do this quarterly. Maybe we should tackle fewer cases next time.
I think so. I think so. We'll tone it down to maybe 10. We'll do more bite-sized tidbits.
Thanks so much. Enjoy it.
Thank you. Good night, all.